The expert speakers are Dr. PRASAD SURENDRAN, Dr. AMITH, Dr. RINOY, and Dr. GANESH. I invite all the speakers to come to the dais. PRASAD. Any answers? Mike.
Respected President, Suresh sir, senior members of KANNUR and my dear friends. Association Indian Medical Association State Annual Conference November 12-13 തീയതികളിൽ നടക്കുകയാണ്. കുന്നംകുളം ബ്രാഞ്ചാണ് എൻ്റെ ഹോസ്റ്റ് ചെയ്യുന്നത്. അത് കഴിഞ്ഞ ഡിസ്ട്രിക്ട് കൺവെൻഷൻ സമയത്ത് അവരെല്ലാവരും ഇവിടെ വന്നിരുന്നു. നമ്മുടെ സഹകരണമൊക്കെ അഭ്യർത്ഥിച്ചിരുന്നു. മെമ്പർഷിപ്പ് അതിന്റെ രജിസ്ട്രേഷൻ ഫീസ് സിംഗിൾ മെമ്പർ 3000 കപ്പിൾ മെമ്പർ 5000 ആണ്. നവംബർ 1 മുതൽ അത് 4000 6000 ആയിട്ട് മാറുന്നുണ്ട്. അപ്പൊ നമുക്ക് കുറച്ച് മെമ്പർമാർ ഇവിടെ രജിസ്റ്റർ ചെയ്യുകയാണെങ്കിൽ അതിന്റെ എല്ലാവർക്കും ഒന്നിച്ച് പോകാം. ഒരു ട്രാൻസ്പോർട്ട് അറേഞ്ച് ചെയ്യാം, അക്കോമഡേഷൻ അറേഞ്ച് ചെയ്യാം. രജിസ്ട്രേഷൻ മെമ്പർമാര് ചെയ്യാം, അക്കോമഡേഷൻ ട്രാൻസ്പോർട്ട് ബ്രാഞ്ചിൽ ചെയ്യാം. അങ്ങനെയാണ് എല്ലാവർക്കും ഒന്നിച്ച് പോകാം. അതിന് പറ്റിയൊരു ധാരണ ഉണ്ടാവണം. ഒന്നുകൂടെ നവംബർ 12-13 തീയതികളിലാണ് അടുത്ത മീറ്റുകൾ. അതിനെ പറ്റിയിട്ട് കൂടുതൽ ചർച്ച ആണ്. താങ്ക് യു. Today's meeting is basically a panel presentation, and moderator will be Dr. Amith, and I will introduce Dr. Amith. Dr. Amith will introduce the other speakers. Dr. Amith is an alumni of Kochi Medical College, and he did MD in respiratory medicine from Cuttack Government Medical College, Odisha, and also did ICU fellowship in critical care from MIMS, Calicut, and he called European Diploma in Critical Care also. And he had worked at MIMS, ASTER, Calicut, currently working as head of department of critical care at ASTER, KANNUR, and also he is a DNB critical care teacher. With these words, I invite Dr. Amith for this evening.
Good evening, everyone. Thank you for the nice introduction. We would like to thank IMA KANNUR for giving us this opportunity to present on this topic, extracorporeal life support, which is a relatively new life-saving technology. And we would like to share the experience as well. So today, the topic will be led by 3 speakers. Dr. PRASAD SURENDRAN, he doesn't need a formal introduction. He's a senior most cardiothoracic surgeon in the region with almost 28 years of experience. He's the director of ECMO services and head of the cardiothoracic surgery department. He'll be talking about cannulation, and he'll be sharing the experience of our patient who underwent ECMO. Then we have Dr. RINOY, who is the consultant in critical care medicine. He has done his MBBS from Calicut Medical College and MD from AIMS, New Delhi, and has completed his fellowship in critical care from BMH Calicut. He's working as a consultant at present in our ICU and is a co-director of ECMO services. Then we have Dr. Ganesh, who is leading the cardiac anesthesia department at ASTER. He has done his MBBS and MD as well as his fellowship in cardiac anesthesia from Calicut Medical College. And he will be dealing with initiation mechanism, the maintenance and complications of it. So I would like to invite Dr. RINOY to start the talk.
Good evening, everyone. First of all, I thank IMA team for giving us the opportunity to talk in this forum. ECMO is basically it's a teamwork thing, and one man or one person alone cannot do this ECMO. That's why we actually decided to present this as a panel kind of presentation. Going into the presentation, I'll be dealing with the initial. Let's see the history of ECMO. So ECMO it's now the preferred term is ECLS, that is extracorporeal life support. It initiated the operation theaters in the 1950s, and the first successful ECLS patient was in 1971, and in 1975 we had the first neonate ECMO survivor. And by 1985, a portable system was developed, and more and more newer advances came, and we are at our current stage of development in ECMO, ECLS. So this is the ELSO registry, the Extracorporeal Life Support Organization, who organizes and supports the therapy. So in this diagram, you can see this is the first neonatal survivor. She's actually very famous, Baby Esperanza. She was a destitute neonate child, and you can see her with the surgeon, Dr. Robert Bartlett, who is considered as the father of ECMO. He initially started, and that baby survived, and she is still. Both of these guys people are still surviving now. And Dr. Bartlett still participates in all these conferences, teaching ECMO and still. So, what is the difference between cardiopulmonary bypass and ECMO? So, ECMO is a modified version of cardiopulmonary bypass machine, which all of us know. And some modifications are there will not be reservoir will not be there, and there are some modifications to make this run for a prolonged time, as opposed to bypass, which is only for a short period in the operation theater. ECMO needs to run for a prolonged period, so there are some modifications that allow this to run. So nowadays, ECMO is being done everywhere. As you can see in the first picture, you can see ECMO is done in an ICU setup. The second one is ECMO. They're initiating ECMO in a supermarket for a patient who had a sudden cardiac arrest in the supermarket, and while CPR is ongoing, they're cannulating the patient and preparing for ECMO. This is another patient who is being transported on ECMO. And this is in the fourth one, there is a patient is walking while she is receiving ECMO treatment. So a lot of advancement has been happening in ECMO, ECLS as a therapy outside of India, and we are actually lagging behind, and it's high time we start offering these services in our country. So try to share a video of this is trying to share a video of eCPR ongoing. I hope you can see the video. Just give us a second. Okay. So as you can see, there is a CPR going on in a patient. This is a machine-guided CPR. The CPR machine is doing CPR, and while at the same time the surgeon is trying to cannulate for ECMO. The one vein has been already been cannulated and trying to cannulate the artery also. And once that is done, the CPR is ongoing, and they are trying to intubate the patient. And then your circuit and everything setup is coming there, and they are primed. The perfusionist and the team is ready with the circuit, primed circuit, and they are trying to. You can see the CPR is still ongoing. They are connecting the circuit and initiating ECMO. Once the ECMO circuit is connected and the pump starts functioning, they can stop CPR and prepare for transport of the patient to wherever is your treatment is going to receive. So these kind of things, for these kind of things to occur, the whole team has to be well trained, and everybody has to know their roles, and they have to work as a very good team. So we are not at this level, and a lot of metro cities in large hospitals they are doing in India itself. And in Kerala, I think we are in the initial stages of giving this kind of therapies. This is the console. They have started the ECMO. You can see the flows and the revolutions of the machine number and all those things. Now they are transporting the patient. So this is what the ultimate aim of the any team who wants to continue with the ECMO services. So back to the presentation. Now the topic will cover the definitions, indications and contraindications, modalities, configurations of ECMO, the machine and circuit components, the physiology of ECMO, practical management, and some details of the current evidence. So most importantly, ECMO is a temporary therapy. It's not a permanent therapy, and it basically gives cardiac or respiratory support to patients with failing heart or lungs. And the most important thing is there should be chance for recovery. So if there is no chance for recovery, like any irreversible thing, you cannot go for ECMO. Basically, it improves the oxygenation and ventilation, and hemodynamic support can be given through the ECLS machine. There are basically two types of ECMO, VV and VA. VV ECMO is veno-venous. It is basically used for lung support of the lungs. VA ECMO is veno-arterial ECMO, which is used for cardiac support. If the patient has both cardiac and respiratory problem, obviously you go for VA, veno-arterial. What are the contraindications? There are some absolute contraindications. Basically, if you have any condition which prevents a meaningful recovery, like advanced metastatic cancer, or a patient has a catastrophic neurological injury, a severe neurological damage, and there is no hope for the patient to come back, you do not put the patient on ECMO. So some of the relative contraindications include any major contraindication to heparinization, like any intracranial bleed, appendix thrombocytopenia, major bleeding. These kind of are relative contraindications. And some other relative contraindications are exposure to injurious mechanical ventilation more than 10 days. Or, similarly, any other irreversible cause of respiratory failure if the patient is not a candidate for lung transplant. So, if there is no definitive therapy, you cannot. ECMO is usually used as a bridge. Is there any clinical evidence? There has been the results of ECMO has been improving over the years. Survival rates are increasing as time run. From the initial 10% poor survival rate in the 70s, we have come a long way. So what has changed? Basically, the technology has improved. Knowledge of ventilator-induced lung injury has come, and anticoagulation intensity has been decreased with the newer tubings and all. All these things help to improve the survival in ECMO patients. What are the indications? Again, VV ECMO, as I have said, basically it is the lung indication for VV ECMO. Anything which can cause a severe refractory hypoxia or hypercapnia, like an ARDS, acute pulmonary embolism, any other similar reversible cause of, especially reversible cause of acute respiratory failure, including alveolar hemorrhage, eosinophilic pneumonia, etc. Graft dysfunction in case of lung transplant. So this is one of the score that we use to whether we can take the patient on ECMO or not, MRI score. Again, the ELSO organization considers uses this definition to consider for ECMO if the risk of mortality is more than 50% or more, and definitely indicated when risk of mortality is 80% of score. That is when MRI score is 3 to 4. So we again coming to VA ECMO. VA ECMO indication is severe cardiorespiratory failure from any reversible cause, which includes cardiogenic shock, septic shock, acute MI, poisoning, again primary graft failure following cardiac surgery, myocarditis, etc. All these are you can see if the primary disease should be reversible in some days. While you give the rest to heart with ECMO and you allow the heart to recover, heart and lungs to recover. As you can see, this is the European Society guidelines for the management of acute decompensated heart failure. So the treatment for with a poor perfusion initially includes, as we know, the loop diuretics, the decongestive treatment, and the other treatment includes inotropic support. Then comes your after the vasopressors and all comes your MCS, that is mechanical circulatory support. This is where ECMO comes in. There are other mechanical support also, like newer methods are available, ventricular assist device, etc. This is one of the methods for mechanical circulatory support. So this one is a 2021 guidelines by the European Society of Cardiology. In ED emergency department also, ECMO is mainly is used when, especially in the similar scenarios like we have already seen, like a CPR scenario. Again, it's difficult thing is when the patient comes in cardiac arrest, you need to decide whether this patient is salvageable or not. That you have to rule out any irreversible other problems. These are the things that is required for so ECMO, as I have mentioned, this is a teamwork. It includes minimum, an ideal team needs at least 2 or 3 intensivists, cardiothoracic surgeons for cannulation, medical officers, and as a cardiac intensivist. Other perfusionist is extremely important for ECMO priming and maintenance. Other supportive cares including respiratory therapists, physiotherapists. Everybody is only if the whole team works perfectly well, you can get a good results in the case of ECMO. We will continue the presentation with the. I invite Dr. PRASAD SURENDRAN to continue with the cannulation and other aspects of ECMO.
Good evening, everybody. And thank you, KANNUR, for giving us the chance to be here before all of you. So, as Dr. RINOY was saying, extracorporeal life support. Now, what it does is, in a failing respiratory system, it takes blood out of the body, oxygenates it as required, removes carbon dioxide, and then puts it back. When the heart, with or without the lung, is failing, then what you do is you take the blood out, you oxygenate it, remove the carbon dioxide as before. But in that case, what you do when you return the blood is you pump it into the arterial side because it is meant to support the circulation also. So we have the 2 modalities of ECMO. One is the veno-venous, which Dr. RINOY mentioned earlier, where the blood is removed from the femoral vein, usually taken to the blood is removed from the femoral vein, taken to the pump, and then it is pumped through the oxygenator. From the oxygenator, gas exchange occurs. Oxygen is delivered to the blood and carbon dioxide is removed. And then this is pumped back into the internal jugular vein. Now, the internal jugular, the cannula actually goes to the internal jugular, the superior vena cava or right atrial junction, and from there the blood goes into the RV and is pumped through the lungs. So since the lung is not working, you provide oxygenated blood to the lung to ensure that what comes into the left side is oxygenated. When you come to a VA ECMO, the blood is removed from the femoral vein as previously, and then it comes to the pump. From the pump, it is pumped through the oxygenator, whereas before gas exchange takes place. And then here it is pumped into the femoral artery, not into the vein. Now in this one here, you need to support the circulation also. So that is why you return the blood into the arterial side so that the body perfusion is maintained. So basically, these are the two types of extracorporeal life support. Everything which comes is some modification of one of these two. You have many minor differences, but those all patient to patient dependent. Now, when you're thinking of starting a patient on ECMO, you need several components: the pump, the oxygenator, the drive unit and the monitor for the pump, and a heat exchanger. Now, each of these are separate components, but they all need to work together as a system to ensure that you get a good outcome. The pumps which we use for extracorporeal life support are, now when you think about fluid pumps, you have basically two types. One is what we use in the heart-lung machine, which is a roller pump. There, a set of rollers actually squeezes the tube in one direction so that the fluid keeps flowing in that direction only. That is something which is useful for short runs, but not for prolonged usage for many days or weeks. And in ECMO, what we use is a centrifugal pump where there is no actual physical squeezing of the blood. The oxygenator is a system where you have a large number of micro tubules which are composed of a semi-permeable membrane, and that allows gas diffusion across the membrane. So on one side you have the gas, and on the other side you have the blood, and the flow rate determines how much of oxygenation you get. The drive unit, there are several companies which make them, and for each drive unit, the pump also is specific. Now, the heat exchanger is necessary because once you take the blood out, especially in ICU where the AC is running very high, you will find that over time the patient becomes very hypothermic and loses temperature very fast. So you have to keep rewarming the blood. Now, the first thing is the pump and the oxygenator are connected in series by suitable tubings, and then the patient is connected to that through cannulas, where you insert the cannula depends on what modality of ECMO you want to do. This is one of the pump heads, which actually is a polymer sort of a cone in which you have, inside which you have, there is a component which is line free, which is rotatable. This one works without any direct contact. It works on magnetic induction principles. And as this white disc inside rotates, it keeps pushing the blood out with the centrifugal force which is generated, and blood comes through this tubing goes back to the patient. Blood from the patient comes through this tubing into the pump. This is, you see here, one of the Mackay pump heads inside the machine. The blood from the patient is coming here, and then through this, it is going back to the patient. This is one of our oxygenators. As I said, inside here you have a large number of microtubules through which blood flows. I mean, so the inside the tube is the oxygen, the air delivery, whatever gas you're using. Usually it's a mixture of compressed air and oxygen. How much oxygen percentage depends on the patient's condition. And outside those tubings, you will find when it's in use, the rest of the oxygenator is filled with blood. Different companies have different configurations. You have adult and pediatric and neonatal, all different. Now this is the ECMO machine which we use. This is actually the drive unit. This is the console which controls the drive unit. And when the patient is connected to this, this is how you will see. This is the machine and the drive unit. And this is the oxygenator with the heat exchanger. These are cannulas which are used for connecting the patient to the ECMO circuit. These are arterial cannulas and these are long venous cannulas. Now, this is a very long venous cannula which, if you put it through the femoral vein, the tip will come into the superior vena cava. Now, when you are starting ECMO, the first thing you have to do is prime the circuit. Now, it has to be completely filled with fluid, no air. And once that is done, the next thing you do is you cannulate the patient. As I said earlier, selecting the vessels for cannulation depend on what modality of ECMO you're going for. Most often it is femoral vein and right internal jugular vein if you're going for veno-venous. If you're going for a veno-arterial, it's a femoral vein and the femoral artery usually on the same side. And how you cannulate depends on the people involved, and basically you have two techniques. One is percutaneous Seldinger technique where you puncture with a needle, pass a guide wire, and then you pass the cannula. The second method is to do a cut down and do an open cannulation. Whichever you use, you need to be sure that when you take the patient off echo, you should be able to repair that opening if necessary. And once you're cannulated, you connect the circuit to the cannula. And then normally we start with a low RPM of maybe around 1,500 to 2,000 revolutions per minute. That will give you some minimum flow. And then you increase the revolutions of the machine so that you get what is your target flow for that patient. Most often we go for around 3 liters per minute for an adult should be all right. But there will be a bit of variation depending on patient weight and body surface area. Now, one very important thing when you think of ECMO is this is a system where, like in a heart-lung machine, you are exposing the blood to a very large non-endothelial external surface area. And all the inflammatory cascades get activated. Anticoagulation is necessary because however well you run things without anticoagulation, you're going to develop clots inside your system, and that will be a catastrophe. So anticoagulation is a must. Most commonly we use heparin with a target ACT of around 180 seconds. ACT is an activated coagulation time. Alternatives to heparin, if for any reason the patient is not getting adequate anticoagulation with heparin, or in a patient who is not responding at all to heparin, then you think of alternatives available here are bivalproline or argatroban. Now these two both are synthetic anticoagulants. They are relatively much more expensive than heparin. I'll hand it over to Dr. Ganesh for going on.
Once again, thank you, KANNUR, for giving us this opportunity to present this overview. I'll be dealing with initiation, maintenance, and weaning off from ECMO. Okay. Initiation of ECMO, there are basically 4 things that we set on the ECMO console. One is the flow, the RPM, then the sweep gas flow, and the FiO2. The flow and the RPM are related. Like as you increase the RPM, the flow also increase. It is supposed to increase. There are many conditions where it does not increase. And then the FiO2 and the sweep gas flow are the gas connections. Right? You have an oxygen connected to the your ECMO machine where you control the gas flow and the FiO2. Okay, basically for VV ECMO, the flow we target is 4 to 6 liters per minute, and for VA 3 to 5 liters per minute. The flow basically means the cardiac output. The rotation per minute, likewise for VV ECMO 3000 to 6000 RPM for both. The FiO2 for both you start at 100% and then you titrate down. And the sweep gas flow, you start at 2 to 4 liters per minute and you titrate down. The sweep gas flow basically is for carbon dioxide removal. The FiO2 oxygenate, it's for the oxygen content of the blood, and the sweep gas flow, the removal of carbon dioxide. During the maintenance, I'll be dealing with anticoagulation, hemodynamic management, ventilation, then the sedation and analgesia, and the general care management. The anticoagulation is done using most commonly used agent is unfractionated heparin because of its availability and it's very cheap. Okay. There are many problems with heparin. The dose of heparin varies from person to person and in the same person from time to time. Okay. Usually we start with a bolus of 50 to 100 units per kilogram bolus and then we continue it with an infusion of 10 units per kilogram per hour. Okay. And it's titrated to effect. That is the ACT. We monitor the ACT every 4th hour. We keep it around 160 to 180 seconds. The ACT itself has problems sometimes, and we monitor the APTT also because the APTT takes time for the result and it's a much costlier test, whereas the ACT is a point of care test. So we correlate between the APTT and ACT, and we continue monitoring with the ACT. And if there's any variation in the ACT, we monitor the APTT. The heparin, there'll be changes in the requirement based on blood product transfusion, use of renal hemodialysis, renal replacement therapy, sepsis, clots in the circuit, heparin resistance. The tests used for monitoring are basically ACT, APTT. The gold standard is anti-factor Xa, and then TEG. The other anticoagulants are the direct thrombin inhibitors, bivalirudin, argatroban, and lepridin. Lepridin is not used now; it's not available also. Whereas bivalirudin and argatroban is now available. Okay, bivalirudin is more commonly used. Okay, bivalirudin, the patient is loaded with 0.5 milligram per kilogram and then a bolus of 2.5 microgram per kilogram per minute. Argatroban, the loading dose is 100 to 150 microgram per kilogram, followed by an infusion of 0.2 to 10 microgram per kilogram per minute. And there are advantages with advantages and disadvantages. So I forgot to mention, argatroban and bivalirudin, you should use APTT to monitor anticoagulation. Advantages are it does not need factors, whereas heparin requires the factors for its effects. Whereas this does not require factors, and moreover, it does not cause complications like HIT, heparin-induced thrombocytopenia. The disadvantages are its availability, its cost, and there is no reversing agent for DTA, direct thrombin inhibitors. The hemodynamic management, we target a heart rate around 100, less than 110, a MAP around mean arterial pressure around 65, urine output more than 0.5 ml per kilogram per hour, a lactate less than 2, and SpO2 is dependent on the ECMO. If it's a VV ECMO, we target for an SpO2 around 85, whereas for a VA ECMO, we keep it, our target is a bit higher, around 90. Ventilation, we call it rest ventilation, where we give the lungs rest. Okay. Basically, it's very low tidal volume with the minimal possible FiO2. We monitor the peak compliance, tidal volume, peak pressures, and FiO2. Basically, we call it ultra protective lung ventilation. This is achieved by basically it's pressure control ventilation with a peak pressure not more than 26. Okay, and a peak of 10, and we target for a tidal volume of around only 3 to less than 6, 3 to 6 milligram per kilogram, ml per kg tidal volume. FiO2, we bring it to as low as possible, 21%. Sedation analgesia, our goals for sedation are to decrease the pain and anxiety of the patient, to decrease the stress response, decrease the oxygen consumption as much as possible, for ventilator synchrony, to avoid neurocognitive sequelae in the ICU like depression, PTSD, dementia, and anxiety, and increase family acceptance of ICU care. Family won't like to see a violent patient, basically. The sedation, the agents used are most commonly the benzodiazepines, like propofol. Then we can use dexmedetomidine, and then opioids, fentanyl. There are all agents. There are some, like for example, propofol. You won't get the effect you find now in a normal patient. On ECMO, a lot of this gets trapped in the oxygenator, the propofol. So patient won't be getting the normal level of propofol. You should use higher doses. Okay. General nursing care, like position changing. This is a VV ECMO especially will take some time. It may take even months. So nursing care is very important. Position changing, bedsore care, back care, daily checking of the insertion sites of the cannula for bleeding, redness, color change. Okay, tracheostomy and endotracheal tube care, bladder and bowel care, and oral care. Monitoring of the patient. In the patient, we check the neurological status for hematomas, bed sores, bleeding, oozing at the cannula site. Position of the cannula, which is very important. Like when you mobilize the patient, when you turn the patient, the cannula can get displaced. Okay, this is checked by the X-ray or the ultrasound. For calf tenderness and distal perfusion. Like that, it's important in VA ECMO where you put when femoral VA ECMO, you cannulate the femoral artery. So distal to the point of cannulation, you have to put another cannula to for distal limb perfusion. Then flow in the distal perfusion cannula, bowel and bladder. The machines, the ECMO, you check the RPM, the rate per minute and the liters per minute. That is the flow and the rotation per minute. Like suppose the patient is vasoconstricted, you won't get the same flow for the same RPM. The flow will decrease because there's resistance on the patient side. And the power supply you have to check daily. The hand crank, which is very important. Sometimes during loss of power supply, you may have to use the hand crank to run the pump. So you should have the hand crank nearby. The clamps, temperature of the heater cooling unit, the sweep gas flow, and the FiO2. In the ventilator, we check the volume, the compliance, the peak pressure. The circuit, the pre-pump pressure, that is the pressure, the circuit before the pump, which is usually negative. It has to be negative. While using a centrifugal pump, it is used actually a suction that's causing the blood flow to the pump. So it's usually around the minus 20 to minus 17. The pre-membrane pressure, the post-membrane pressure, the difference of which is the delta pressure, which is very important. And the delta pressure varies from each manufacturer, each oxygenator. Like for a Mackie, it is for each company, it's a different delta pressure. Then the flashlight test, which should be done daily, it's a simple test where you shine a torch on the oxygenator to see for any clots. Okay. Recirculation, the color change of both the tubes, you should check. Okay. ABG from the circuit, position of the cannulas, and pump head or auscultation. If there is any bubble trap, you will hear it on auscultation. The labs, the routine lab parameters like the CBC, RFT, LFT, which is checked daily. The ACT, as I told, is done 4th hourly. APTT, twice daily you do it. And if the ACT and the APT does not match, then you have to do it more frequently. The chest X-ray you do daily to check for your improvement. LDH to check for hemolysis. That will smear for hemolysis. For infections, you have to check the procal and the CRP if you suspect infections. The pre and the post membrane ABG. Complications. The normal complications are bleeding, DIC, sepsis, pneumothorax, stroke, distal limb ischemia, pump failure, oxygenator malfunction, tube kinking, dislodgement of the tubes, air embolism. Troubleshooting is when there is hypoxemia, you check the oxygenator function and change the oxygenator if needed. Increase the flows by increasing the rotations per minute. Check for recirculation, which I'll explain a bit later. Confirm the cannula positions. The FiO2 setting in the ECMO machine you can increase, and transfuse PRBC if required. If there's hypercarbia, all you can do is increase the sweet gas. Then this is one specific complication you see in a VA ECMO. It's called Harlequin syndrome or North-South syndrome. This is seen in VA ECMO. Once the heart starts, usually in VA ECMO, what the blood that the heart is receiving actually deoxygenated blood. So once the circulation is done through the femoral arteries. Okay. So the oxygenated blood is given to the femoral artery. So once the heart starts improving, it will start pumping this deoxygenated blood, okay, against the ECMO flow. So when you check the you'll find desaturation in the upper half, like initially from the right upper limb, you will get deoxygenation saturation part, whereas the lower limb will be having a good perfusion. It's called a North-South syndrome or a Harlequin syndrome. It shows that the heart is improving actually, and the lung is going bad. Okay. And you can sort it out by putting, going for a hybrid ECMO, like it's called a veno-veno arterial, where a return cannula is one more return cannula. One return is already in the femoral artery. You put one more return cannula into the IJ. This is sort out the problem. Okay. Then in VV ECMO, there's another complication. VV ECMO, there's a specific complication, that is recirculation. Recirculation usually happens if the draining and the return cannula is too close. Usually we place the draining cannula is placed through the femoral vein. It is placed at the junction of the IVC and the right atrium. The return cannula through the IJV at the junction of the SVC and the right atrium. They say there should be at least a distance of 10 centimeter between the tips of both these cannulas to prevent recirculation, or else all the blood that is being pumped through the return cannula will be drained through the. So, in the weaning criteria, weaning starts like usually weaning once there's improvement in the condition of the patient. A cardiac status, if the mean arterial pressure is firstly over 70 with an SpO2 of over 95 and a pulse pressure more than 20, and echo shows an improvement in the EF, we go start weaning from a VA. For a respiratory VV ECMO, we check the chest X-ray daily, we check the ABG and the compliance of the lung. If it is more than 20, we plan weaning. Weaning from a VV ECMO is by decreasing the FiO2 and the sweet gas flow. We decrease it to minimum and gradually increase the ventilator settings. So, and then we give a trial off. That is, we give 24 hours. The circuit will be running without oxygenation from the ECMO, whereas the ventilator will be functioning normally like any sick patient. And then if the patient holds on for, it's called a trial off. If the patient holds on for 24 hours, we plan decannulation of the patient. For VA ECMO, it's a bit more complicated. VA ECMO, we slowly decrease the flows by around 10 ml per kilogram per hour. We bring it down till the flow reaches around 800 ml per minute. That is the minimal flow. That's called a minimal flow. And then we increase the ventilator settings. And then there's something called a bridge, which is connected between, for a femoral VA ECMO, we just near the drainage and the insertion sites, there's a connection between the two cannulas. So one circuit runs simply through that, actually bypasses the patient. We bypass the patient from the ECMO and keep him for around 2 to 3 hours. If the patient holds on, we plan decannulation of the patient. So this is to speak about our experience. We actually did our first ECMO a few weeks back, and we successfully weaned him off ECMO also. And he's doing well actually now. So to speak about that.
So we had a 62-year-old male recently came to us with severe pneumonitis in ARDS. He was intubated on the ventilator for 24 hours. Even with maximum ventilation support, actually wasn't improving. Proning was started. Even with prolonged proning, there was no improvement, and the patient started to deteriorate. So that was when we thought about initiating ECMO. That patient was a relatively healthy patient, physically a very active person, healthy with no comorbidities, and he was a salvageable patient. So we considered ECMO when at this stage. If you look at this, FiO2 on an FiO2 of 100%, that is 100% oxygen. His PO2 is only in the 40s, 40.5. 40.5 is an abysmally low PO2 for 100% oxygen. This was even after 24 hours of full mechanical ventilator support with proning, and we started on ECMO. So this patient was put on veno-venous ECMO, and you will see once the ECMO started, this dark blood is actually the femoral venous cannula draining blood to the ECMO circuit, and then it is getting oxygenated. And here on the side, you find blood returning back to the internal jugular vein. Now, if you look at the color of these two, there's a marked difference here. And 1 week after ECMO, you will find on an FiO2 of 40%, FiO2 with a peak that is an expiratory pressure of 10, his PO2 has come to 64. Once we started ECMO, actually we were starting ECMO, his saturation was in the 60s. When we initiated ECMO, that gradually came up, and then throughout we were able to ventilate around 95, above 90, with minimum support. And the lung ventilation, actually, when you start ECMO, goes down to what we call the ultra-protective lung ventilation. That is basically just to keep the lungs aerated without giving any additional pressure effects, because barotrauma is the worst thing in these patients. And that is the reason why ECMO gives a much better outcome than conventional ventilation, because ECMO allows the lung to rest. In conventional ventilation, what happens is you're actually stressing the lung even more. So in this patient, in 1 week, his lungs had recovered sufficiently that with FiO2 of 40, his PO2 had come to about 60, steadily, persistently above 60. There was not much fluctuation, he was stable on that. And that is when we decided to decannulate. So decannulation is you have to remove those two cannulas. While you're doing it, you have to make sure that you repair the puncture sites in the vein. When you put a cannula for maybe a couple of days, it's fine. You can just apply pressure over the site for long enough so that the opening closes off and the track also closes off. When you have a prolonged cannulation, what happens is it forms a track there. So that will remain as a fistula unless you surgically close it. And in this patient, once we remove the cannulas, we open both the sides. There is the right groin and the right side of the neck. Look at the femoral vein and the interventricular vein. And the patient was continued on minimum mechanical ventilation, that is with conventional means. This is where you see the patient is during the ECMO run. This is the patient, the ECMO circuit pumping, the oxygenator here. This is the console, and this is the monitor, the invasive monitor, which gives you all the pressure readings and patient characteristics. This is the initial X-ray. If you look at it, both the lung fields were almost completely laid out. This is the patient 1 week later, after we decannulated. He's in a recliner. You can see we have a pressure pressing over the site of the interventricular decannulation. And the lung, it is definitely not a normal lung. The lung, radiologically, it takes much more time for the lung to show a really good resolution. But the lung function is markedly improved. And as Dr. RINOY said earlier, this is something which is very much dependent on multiple inputs. You need a lot of people who can contribute different things, because everything is, it involves a lot of very specialized care. And these are some of the people involved in our team. So thank you all for your patient listening. So ECMO has come to KANNUR, and we intend to take it forward gradually, making sure that the results remain acceptable. And as again was said earlier, one thing we'll be very careful about is ECMO is not something which can be offered to every patient, because you have to have a patient who is recoverable. Either recoverable, or otherwise a patient who is a transplant candidate already on a list where you just want to keep him alive until the transplant. Otherwise, in an irrecoverable, unsalvageable patient, there is no indication. So, thank you, everybody.
You see many patients pulmonary complications. Basically, also
actually, it could have actually he was on ECMO, but many of the patients actually in the COVID era is when ECMO really came up in a big way. There are a lot of patients who I cannot admit, but survived only. And
this is actually something which you can have patients who come in So these incentive programs are definitely a very good indication because most of the people they have out of the infection then they started COVID. COVID is not COVID. Definitely is a huge case number which came out in the last 2 years. A lot of centers started with that and have gone on to very experience.
Regarding COPD, the patients might have like those are refractory high hypercarbon, like very high carbon dioxide levels. There is a second thing called E4, that is basically extracorporeal carbon dioxide removal. That can be done. That is actually very simple. That can be done even with a dialysis machine and a pediatric oxygen user. Almost possible. And the cost might also come down. We didn't discuss about the cost during the presentation. Will come down. That doesn't revert the pathology anyway. This is always a support, just like the ventilator. COVID. Initially during COVID, there was a lot of confusion regarding whether to ventilate or whether to go with an NIV, whether not to go with an NIV. So what happened was the hierarchy of treatment. We used to start with a slow flow oxygen, then some patients might have so the then was selected for a case was when there was no way out, patient is not 100%. So at that point of time, even ventilation for maybe a week or so. So by that time, the lung is already that lung has been put on, and that's the ventilated is also sets in. So at that point of time, it is almost recoverable. So the point is, we have to do that. Like we see in our patient, after 24 hours of no ventilation, so what we can do is a lung protective ventilation. Previously, we used to do like hydrovolume 10 to 12 per page. So that was a large volume, and that blocks all this direct from that actually causes more damage to the lung. So how comes the lung protective? So we evolved over all these years, the management of it has come down to 6 ml per kg. And now when we give ECMO, if you have noticed, the ventilation strategy what we use is protective. That's very just to keep the lungs open. Or we call it a lung burst. So that gives the lung opportunity to heat and make it better. So that is the advantage with ECMO. So it's not an option which has to be considered once everything fails. So once we know that the patient is not improving with ventilation, the oxygenation is not getting better. We do a pro ventilation. Even with that, the patient is not improving. The best thing is to go for an ECMO. So most of the trials have shown, like initial, some of the trials have shown negative results because this was chosen at the end of all these efforts, like all of the ventilation. Once everything and that was supposed to be consider this as an added support. Yes, definitely. Is the IT system centers now where you have you know that he has recoverable cardiac condition. Maybe the stunning which is not responding to any that is what you do is you put it on ECMO, then you let it process because the pump is going to go on the so you when you put a patient on angios, what is happening is actually going to be more because you want to maintain the circulation. So in this now what you do is you do the opposite. You put the patient on ECMO so the circulation and maintain through the ECMO circuit. And then you get the heart press. So the heart rate is not press. It is not very common because most of the patients will come up with pharmacological support and sometimes with additional but definitely it is used as a surgery there are indications and it is not something we take very
because this is probably the most invasive treatment modality available in the world at present. So, one indication, definitely it is life saving, but not something we can take.
Maximum how many days you can do?
This can be carried for months. DV in many cases have been done for many weeks. VA is usually, because the heart usually tends to recover faster. If it is a recoverable condition, the heart tends to recover faster. In most cases in VA, they usually come off in about a week. In a VA, if there's a renal artery device basically the support of the heart. In those cases, if the patient doesn't improve within maybe a week or two, then you start thinking whether this patient is not salvageable, whether you should go for some other form of therapy. The only other two options in that case are referential access device. That also is not a permanent solution. That again is a bridge to transplant. So in those cases, you think of a bridge to transplant. In this VED, when you're supporting the lung usually takes much longer to recover. And many of these COVID patients have been for a few months on VA. The thing is, you need to be careful about two things. One is your cannulation size. Bleeding is a big issue. That you have to be very careful about, and you have to be very, very meticulous in making sure that the size are clean and not bleeding. The other thing is, for continuing these patients on ECMO, certain ones you might have to change the oxygenator, certain things. That is an additional huge cost. Cost is one thing which prohibits a very long term. But yes, we can keep them on ECMO for a few months.
Regarding the surgeries, again, the VV ECMO is supporting the lung. Can be done for tracheal surgeries as well as tracheal stenting. So, intervention so those patients who require tracheal stenting on some centers do it on ECMO support, VV ECMO support. Regarding the cost,
the cost is very high, but now it's coming down actually. Like our center actually for the ECMO, the circuit itself costs few lakhs actually. So once the circuit is open, then even for one set will have an oxygenator or one pump head, and then cost of actually it comes to around 4.5 lakhs for the first 1 week. Okay. And then comes to the investigation and then after that it will be even lower, it will be around 20,000. And actually everywhere is coming down to much costlier. Now people are using, rather than these electronic circuits, people are making their own circuits. Which even brings down the cost.
cost of the consumables are more.
Yeah, it's coming down.
Now that more people are using, it's a usual supply demand thing. So once more people are using, then per piece cost comes down to slightly.
How long does it take to buy the machine and then emergency system?
Well, that is where your team becomes important, because you have a professional who is used to doing these things, you can do it in a couple of minutes. The person who is unused to doing it may take up to an hour. So it all depends, but in most should I say, most centers where they have a smooth unit which has been working together for a long time, it takes them only a few minutes to find the circuit and get the circuit ready. Now, if you're starting, actually, you will need you can't need with just 1 or 2 people. You will need two people at least trying to you need another people who are starting with the here. Then do other patient things like ventilator, patient's general condition, medications, and things like that. So it depends. If you have adequate people involved, then you can do it actually in 20 minutes and get the whole
if always you make it longer because the same person is doing the priming and then doing the calculation. This is one of them.
Our social is very, very important. Because of this course and our thing, value should have to get it. Actually, our successful for us.
We cannot even exercise to give but the exam that very important. And also, being custom worker was a solid with the rules.